to the demo.
This was really good. As you heard in the previous chapter, you will encounter prosthetic valves very frequently in your daily clinical routine. Even more so, it's important to pick up if there is a problem.
So let us now go back to echo and look at how we can detect if something is wrong. Just as a review, this is what we are looking for. So let us start with the mitral valve and see how we can use Doppler to look at two important complications: obstruction and paravalvular regurgitation.
Yes, we need to discuss the issue of gradients, so let's go to the scanner.
Our patient was operated 14 years ago because of flail leaflets of the mitral valve, and now he has this mechanical prosthesis, and we want to assess the function. He's doing really well, but still we need regular follow-ups.
Exactly. So the first thing we do is we look at the color Doppler looking for regurgitation. I do this first in a 4-chamber view, and I scan the entire mitral valve up and down. And what is very important is to use atypical views, because these regurgitant jets can really be very hidden behind the artifacts that you have in the left atrium. So if I use atypical views where I slant the septum either to this side or to this side, I can look for regurgitant jets at the medial and the proximal portion.
Yes, because you have always to look for valvular regurgitation and paravalvular regurgitation. And Thomas is showing us that especially when you look for paravalvular jet, you can use the parasternal long axis view.
Yes, it's my favorite view actually, because here we can look at portions of the mitral valve that are free of artifacts, especially the portion which is close to the aortic valve and the intervalvular fibrosa. So my recommendation is to use this color Doppler view as well, and both ends of the mitral valve can be scanned. So this would be the assessment using color Doppler for regurgitation, but we need to look at another common complication that can occur in mechanical prosthesis, which is
obstruction, of course, so we look for any degree of obstruction. And to do this, apart from looking at the prosthesis, we need to use a continuous wave.
So here's the continuous wave Doppler. We're expecting higher velocities. That's why we use continuous wave Doppler. I try to optimize the sweep speed. In this case, it's optimal already. And what do we do then? We simply trace the spectrum and calculate the mean gradient. I'm doing this right now. And here we have the mean gradient, which is somewhere in the range of 7 millimeters of mercury. So that's quite normal. And then finally what I do is I look at the pressure half-time. This is the deceleration of the initial part of the mitral valve. Inflow, here we have a velocity, a deceleration time of 106 for the pressure half-time, which means it's rather steep, which means there is no obstruction.
In conclusion, we have a normal prosthetic valve which works fine without any significant degree of obstruction or regurgitation.
So what are the normal gradients?
Well, the gradients depend, first of all, on the size of the prosthesis and also on the model of the prosthesis, but it's somewhere in the range between 2 to 8 millimeters of mercury. So keep in mind, and this is our third rule, we need 2D for morphology, we need spectral Doppler for gradients, continuous wave Doppler most of the time, and we need color Doppler to look for mitral regurgitation or aortic regurgitation. Here is an example of a patient who has a small paravalvular leak. Remember, this is my favorite view actually to detect such leaks, the parasternal long axis view, where you do not have shadowing of this anterior portion of the mitral valve, and you can nicely see this rather small, probably I think insignificant paravalvular leak. Here is another example, this time of a patient who not only has a pericardial effusion, as you can see, but also a perivalvular leak right here in the lateral rim of the prosthesis. It's very nice to see that a jet regurgitates here from the rim of the prosthesis. And here a beautiful example of a patient who has a very, very large paravalvular leakage. You can see that the jet is very broad, originating probably from the medial part of the mitral valve right here. And this is an example of a TE study, because many of these Paravalvular leakage cannot be seen from transthoracic echo. Remember, we have the problem of shadowing, and especially in eccentric jets, that's where TE usually has the edge. A beautiful example of a jet that kind of encircles the entire left atrium in a patient with a mechanical prosthesis.
Okay, back from TEE to TTE. Anna wants to explain something else to us.
But we are not done yet. We need to look at left ventricular function. We do it from the short axis view in parasternal approach, and we can say the function is preserved.
Right.
But remember, use more views. Also from the apical four-chamber view, we could see the abnormal motion of the interventricular septum, but all in all, we can say the left ventricular function is preserved.
Remember, many patients who received a prosthetic valve already had some degree of impaired left ventricular function before surgery. And in some, left ventricular dysfunction is masked. And after surgery, left ventricular function decreases.
And surgery also affects left ventricular function. Let's hear what Bruno says.
The most important causes of left ventricular dysfunction after a valve operation are mostly surgical complication or anesthesiological complication.
And here's such an example of a patient who has poor left ventricular function after mitral valve replacement. This patient was simply operated too late, and he already had some form of left ventricular impairment, and after operation, ventricular function deteriorated even further. So, the fourth teaching point is,
don't forget about the left ventricular function.
now let us turn to another patient and see how we can use color Doppler and continuous wave Doppler to look at the aortic valve.
Our patient is 52 years old, and 14 years ago, he received the first prosthetic valve in aortic position, and this operation was associated with replacement of the ascending aorta, and later on he treated also the mitral valve, receiving another mechanical prosthesis. He's doing very well, and today we have a regular follow-up, and we will show you how to assess the prosthesis on aortic position.
Yes, and to do that, we do something that we also perform in aortic stenosis. We try to get a 5-chamber view where we have a good orientation between the flow of blood through the aortic annulus, in this case the prosthesis, then place a continuous wave Doppler spectrum inside, see that we have the sample volume or the focal point right at the region of the prosthesis, and then we freeze the image and quantify here the signal. In this case, we just trace the signal and we get both the maximal and a mean gradient. In this case, the maximal velocity is 2.2 meters, which means we have a maximal gradient of 20 millimeters of mercury and a mean gradient of 12 millimeters of mercury. So a completely normal velocity. The thing that I want to show you, though, is that if you look at the tracing, you will see that there are two very bright echoes, one at the beginning and one at the end of the signal. And this is indicative of a mechanical prosthesis. You will not have that in a biological prosthesis. So this is a way of distinguishing the two. Now, of course, you could also perform auscultation, but in the times of echo, who uses a stethoscope anyway, right, Anna?
It's true. And to conclude actually our assessment, I would also look for regurgitation.
Right. So to look at regurgitation, I would do a number of things. The first, I would perform, again, 5-chamber view and look for a regurgitant jet.
So remember, this patient underwent Bentel procedure. So actually, we are looking for valvular regurgitation, because in a Bentel procedure, actually, we cannot have paravalvular leak.
Yeah, so this is just for demo purposes. We cannot expect to have paravalvular leakage. But what you do is you put the color Doppler there, then you turn in all directions, try to tilt the transducer to see if you see a region where we do have paravalvular regurgitation. And finally, I would do the same thing in a parasternal long axis view. This is actually quite good for eccentric regurgitant jets. Of course, in this patient, we do not have a jet. And then finally, I would also look at for regurgitation in a short axis view, because here you can sometimes see exactly where the origin of regurgitant jet is.
Remember, assessing aortic valve prosthesis is the same as assessing aortic stenosis and aortic regurgitation. With continuous wave Doppler, you measure the velocities across the valve and you calculate the gradients, while with color Doppler, you exclude regurgitation.
And what you're trying to detect with echocardiography is something like this, obstruction. Here we have two examples. On the left-hand side, fluoroscopy of a normal bileaflet valve, and on the right, where one cusp or one disc is actually stuck. But what are the normal gradients of an aortic valve prosthesis?
Well, usually the normal gradients are about 20 to 35 millimeters of mercury, depending on the size and the model of the prosthesis.
Okay, now let's see some examples of prosthetic valve obstruction. Here is a patient who came in with severe dyspnea. He didn't take his warfarin for several weeks, and this is what happened. You can see on the 2D image that ventricular function is probably somewhat reduced, and there's a kind of a strange motion of the shadowing of the disc. And then if you look on the color Doppler, you see that there is probably some turbulent flow, but you cannot really detect obstruction unless you use continuous wave Doppler. And this is the tracing you get. You see there is a very high velocity, a velocity which denotes stenosis, and therefore you've almost made the diagnosis of obstruction already. You've got the clinical picture of a patient not taking his warfarin combined with a very high velocity.
Now here we have a case of a patient with paravalvular aortic regurgitation. You can nicely see the jet, the turbulent jet across the valve. And this is highlighted even further in the short axis view, here on the right side.
Yes, the short axis view is a very good view to actually detect such defects and where you can really see where the origin is. I think it's quite nice to see that the origin of this regurgitant jet is right here, and the flow goes kind of almost, I would say, perpendicular to the normal axis of the aorta. So this is the origin of the regurgitant jet, a paravalvular leakage. So we've seen a number of pathologies of mechanical valves, both in the aortic and the mitral position. But what about biological valves? Is assessment of biological valves really different?
Well, it is actually similar, but in biological valves, there is less shadowing and there is a higher incidence of structural failure. Let's see some examples. Obstruction of the bioprosthesis. Can you see that the patient also has pulmonary hypertension? There's flattening of the intraventricular septum.
Is this actually a biological valve? Well, yes, because you can see two of the three struts, which are typical for bioprosthetic valves. And see how turbulent the inflow across the valve is. And how high should the gradients actually be to diagnose patients with obstruction or structural failure?
Well, as a review, they should not be more than 5 to 8 millimeters mercury.
Yes, and if you look at this example, the mean gradient is, what is it here? 15.2. So very, very high. No question, this is prosthetic valve obstruction.
Here is a TEE example of paravalvular aortic regurgitation to show that the defects are often little slits. So what is the role of TEE in general?
Well, I think TE plays a very important role, especially in prosthetic valves because of shadowing, because you can detect eccentric jets. So I think TE is very, very important. If you have a patient who, for example, has unexplained dyspnea with a prosthesis, bad image quality, or even hemolysis, I think you should go for transesophageal echocardiography.
And that brings us to our fifth teaching point. Look for structural failure in biological valves.
Now it's your turn.
Is this a normal mechanical valve in aortic position or not? Look at the valve, look at the flow. And here are the gradients. Is this normal? Well, the mean gradient is 26.
Well, I would say that is still in the range of normal. And if you look at the color Doppler we saw previously, I don't see any regurgitation. So what do you say, Jutta?
Yeah, I think this would be in the normal range.
Yes, that would be a completely normal prosthetic valve. And what about here?
Well, here you see a mechanical valve in mitral position. And if you look closely, you see this turbulent jet. It's a paravalvular leak.
Yeah, you have to use very atypical views frequently to detect such leaks, as you can see on the right image here with the blue jet going away from the transducer. There's one more important topic that we actually covered in a previous chapter, but we need to mention it once more. And that is the topic of prosthetic valve endocarditis. Now, why are patients with prosthetic valves at such high risk of endocarditis? There are several reasons. One is that there is a direct contamination with bacteria during surgery, and patients can, of course, get their valves infected, especially in the region where the valve is not endothelialized, exactly the suture lines or maybe even the ring of the prosthesis. In addition, patients with prosthetic valve have higher flow velocities and they can cause endothelial damage and therefore also predispose to endocarditis. And endocarditis can have devastating effects. Here is a terrible example that shows you what can happen in such patients. You see a huge abscess in a patient with a prosthesis. You see a vegetation here and a large abscess here surrounding the aortic valve prosthesis. And what else do you see?
Well, there's actually even a dehiscence around the valve.
Yeah, a very dramatic complication actually.
So a TE should definitely be performed if there is suspicion of endocarditis or in a patient with fever, because the vegetations can be very small and you may not be able to see them with TTE. And TE also discovers other complications of endocarditis.
Yes, for example, you sometimes have paravalvular leakages, or you might have fistulas and all sorts of things that are also important complications of endocarditis.
Here you see a patient with obstruction due to the vegetation.
Yes, you see that the patient has high velocities probably across the valve, but also that there is regurgitation. Here's another example of a patient who probably has dehiscence. Here you see there's actually a hole here from where the jet actually originates, and you have a tilting motion of the disc as well, of the leaflet as well. Again, highly suspective of endocarditis. And as Jutta mentioned, endocarditis can really be detected well, especially in prosthetic valves, if you use TE. Again, an example where you can see a very small vegetation actually here on the valve that we probably didn't detect from a transthoracic approach. So definitely, especially in prosthetic valves, TE has the edge over transthoracic echo. Here you can see the same patient now with some degree of aortic regurgitation, which is always, a sign that an infection could be present. Jutta, do you want to say something to this following case?
Well, this is another case. You can see the pseudoaneurysm and an abscess around this mechanical valve.
Yeah, it's always very important to look at the surrounding of the valves as well, because that's where you often have the infection present. And another example, very similar to the ones we showed you previously. Again, abscess formation, very dense tissue surrounding the aortic valve. You can see that there is a little cavity here, and the risk here would be that this breaks through and you have fistulas and all sorts of other complications. Okay, but this brings us to our sixth and very important teaching point. Infection in the setting of prosthetic valves is always highly suspicious of endocarditis. So we're now through with prosthetic valves.
Yes, but we have not fully covered the topic. We also need to look at mitral valve repair. We need to talk about the importance and why it is implanted.
Yes, it's of course very important that mitral valve is not always replaced but repaired, because actually it preserves left ventricular function, has probably less risk of endocarditis. You don't need anticoagulation. And if you repair the valve, actually in all cases you also implant a so-called annuloplasty ring. And there's different models out there which look a little bit different, but this is the key feature that you'll also be looking for on the echocardiogram. And this is how an annuloplasty ring looks in 3D. A fascinating image. You can even see where the sutures have been placed. And what are the things you should look for in patients who have annuloplasty rings and repair?
Well, first of all, we have to look, is the mitral valve still competent? Do we have mitral regurgitation again? And also the mitral annuloplasty ring can cause obstruction and stenosis. And finally, we have to consider the left ventricular function.
Okay, here's an example of a mitral annuloplasty ring seen in a parasternal long axis view. I think it's quite apparent that the ring is right here and here. This is two parts of the ring which are hit orthogonally right at the base of the mitral valve. And here we have a 4-chamber view. Again, the ring here and on the other side. But there are some differential diagnoses, aren't there?
You know, sometimes it can be difficult to actually see the annuloplasty ring. And the differential diagnosis is annular calcification, especially in elderly patients.
Now, this is such an example here. You see massive calcification here, and there's a shadow here caused by the calcification. And if you look on the short axis view, you see that the calcification encompasses a large part actually of the posterior ring. This is in contrast to an annuloplasty ring where you would have the echo-dense material surrounding the mitral valve. And if we now go to this problem, what is the problem here?
Well, here you can see this turbulent flow across the annuloplasty ring. So it's a case of stenosis after mitral repair.
I guess it was just an undersized ring. That is sometimes done, especially in patients who have cardiomyopathy. And by undersizing the ring, you can cause some degree of stenosis. And finally, if we place a continuous wave Doppler through the mitral valve here, we see that indeed there is a gradient across the valve higher than normal.
But much more frequent, you see recurrent regurgitation following the repair. This is a case where you can nicely see there is significant mitral regurgitation after surgery.
This is actually an interesting patient because this patient had artificial cords. You can see them attached actually right here. You see the cords attached to the papillary muscle here. And the patient actually presented with hemolysis simply because there were such shear forces caused by the cord and by the eccentric jet that the red blood cells were destroyed. And again, we have severe regurgitation now with the problem of hemolysis, and he had to be reoperated. So something that we can see even in patients with mitral valve repair. But altogether, that brings us to the next and 7th key point that we want to make.
You really always have to check for regurgitation after mitral valve repair.
This basically concludes our chapter. We still want to highlight again once more all of our teaching points. Jutta.
Well, first of all, prosthetic valves carry a lot of risk for complications, especially for regurgitation, obstruction, and endocarditis. 2, there are different types of prostheses. We have the mechanical valves and the biological valves. 3, 2D is needed for the morphology of the valve. Spectral Doppler is needed for the gradients. And finally, the color Doppler is needed to detect regurgitation. 4, don't forget to look at the left ventricular function. 5, look for structural failure in biological valves. 6, infection and prosthetic valve. Remember, always look for endocarditis and perform a TEE if there is suspicion. 7, check for regurgitation after mitral valve repair.
And 8, thank you for watching.